I am so honored today to be interviewing one of my newest medical advisors, Dr. Tiwari. He is a plastic surgeon, a microsurgeon, and he's going to help us take a deep dive into deep flap reconstruction. A lot of patients don't know a lot about deep flap. I want to ask you, Dr. Tiwari, who tell us a little bit about yourself and why you wanted to be a Learn Look Locate medical advisor.
Well, thank you, Cynthia. This is a real honor. I like what you did there, deep dive in a deep flap. So I'm very excited to have this conversation. And we had a patient who I think you know well, who had undergone a DIEP flap, and she's the person that turned me on to you, and I think you onto our practice. And she's somebody that I've had the pleasure to care for quite some time now. And in just learning about you and your group, what I see is a very patient-focused and, to be fair, very unique approach to patient education. I think you really do a great job combining very high quality information that's physician driven, along with sort of a platform that is easy for patients to approach. So kudos to you for everything that you've put together. And I wanted to be involved with this project because I really do think you're doing some incredible work here. So thank you for the invitation.
Absolutely. Thank you. And we're so honored to have you because so many women still go through breast cancer treatment without ever hearing, including me, deep flap reconstruction. Why do you think that is, Dr. Torrey?
Yeah, I think that's shocking still in 2025, but it's not surprising. So, although it may be shocking, I don't think it's surprising. I think that deep flap is certainly more common than it was 10, 15 years ago. Um, but it still requires a lot of expertise, a lot of training, a
Mhm.
lot of experience in this area. And to be fair, there aren't that many places where surgeons have what I would consider the requisite experience to do a DIEP flap in a efficient, aesthetic, reconstructive fashion. And I think for that reason, um, you find that patients are either not offered DIP flap reconstruction or are told that they are not candidates for it because they are too, uh, insert the adjective. Your body mass index is too high, your body mass index is too low, you're too young, you're too old. These are all justifications that are sometimes used, but they don't really go to the heart of the problem, which
Right.
is really understanding how to individualize the reconstruction to the patient. And I always tell patients that, it's not that deep flaps are good and implants are bad, or implants are good and deep flaps are bad. It's really understanding the patient, understanding her needs,
Mhm.
understanding the cancer treatment that she's going through, and then taking the time to individuate a reconstruction that meets not only her anatomy, but also kind of her quality of life
Mhm.
specifications. So it is a lengthy discussion, but I think the ability to bring in these different concepts and to have a patient-centered discussion is ultimately what we want from any plastic surgeon, certainly a deep flap surgeon. But to answer your question directly, I think that the numbers of people that can do this in a very kind of high quality way, it's hard to find them because it takes a long time to develop those skills.
So do you think, like, for instance, for myself being treated at a major cancer center, they didn't bring it up because they don't do it? Is that what's happening? I mean, it's
I do think that
frustrating.
that's an element of it. I think that you know, at some level, among surgeons, among physicians, really among anybody, you kind of go with what you're most comfortable doing. And if you're not comfortable doing something, then you're not really educating patients in that area.
I
And so I think
see.
it is a bit of a self-fulfilling cycle. If the
Yeah.
surgeon is not comfortable with that type of reconstruction, he or she may not present that option. He or she may not encourage that option, even though
Yeah.
it may be the best for the patient. And it puts
Mhm.
patients in difficult positions because it's hard for them to know, am
Oh,
I
yeah.
really not a candidate,
Yeah.
or is this surgeon is this not in his or her pattern of practice? And that's where I think websites like yours are very helpful, because patients do at some level have to be their own advocates and
Yes.
search out these options.
Yes, we do.
I think now with telehealth and the ability to do consultations just over Zoom or what have you, it makes that barrier a bit easier, at least to get information. It's very easy for me to talk to a patient. Maybe I review some pictures prior to let them know with a high degree of certainty whether I think they're a candidate or not for
Okay.
deep flap reconstruction. I think that there are better ways to get information now than we've ever had.
Hmm.
Obviously, through platforms like yours, through telehealth, through AI, there are a lot of ways to get high quality information. So it's not to say that one should disregard the opinions of the expert to whom you are referred, but I
Hmm.
do think that it is a fair statement to say um, that one must be able to trust but verify. And verification here really comes from talking to other people that
Hmm.
may have a higher degree of comfort when it comes to this particular type of autologous reconstruction.
Mm. So, how would you explain to someone newly diagnosed what deep flap is? I mean, this is, on top of estrogen positive, HER2 negative, this is a word we've never heard before. And it is an acronym, from my understanding, right?
Yeah.
So, if you could help us break it down in a really patient friendly way so that women that are considering this understand.
Yeah, I think the best way to think about a DIEP flap, a deep inferior epigastric artery perforator flap, is that you're using the skin and fat from your tummy. No muscle, just skin and fat. So it's like a tummy tuck. You're using that same tissue
Mm.
that would be removed at the time of a tummy tuck, but instead of discarding it, you're transplanting it based on its blood
Wow,
vessels. And I always tell patients, it's always been your tissue. It's still your tissue. It's just in a different location. So
that's
rather than being in the
incredible.
abdomen, it's in the chest area. And because it's your own tissue, as you gain weight, it gains weight. As you lose weight, it loses weight. It provides the most natural, long-term, durable reconstruction over time with the
Mm.
least potential for reoperative surgery. Scar soften over time, tissue softens over time. We can hook up a nerve that's known as resensation surgery. So in many ways, the deep flap is probably the gold standard for breast cancer reconstruction, certainly when it comes to autologous, natural tissue reconstruction, avoiding an implant. So I think that gives patients a sense of what we're doing, which is taking that kind of lower poochy skin and fat that we all have and using that for your reconstruction. And most people are pretty proportional. You've got about as much skin and fat at your lower tummy as you need for a breast reconstruction.
What about women that are getting turned away when they're saying you don't have enough body fat? I mean, is that something you guys talk about? That
Yeah,
could
I
happen.
think this is a more nuanced conversation. So,
Hmm.
are there patients that are just flat out too thin for
Hmm.
DIP flap? Absolutely. There are people that are
Okay,
too thin.
you just can't do it.
But yeah, I would say that there are fewer patients like that than you would assume.
Okay.
If someone was had 10% body fat and under, which is very
Mm.
low for a woman, I think that person would not be a candidate. If you had a body mass index in the normal range, certainly if you've had children, I think the likelihood that you're a candidate for DIP flap is fairly high. It doesn't mean it's
Hmm.
the right operation for you. We're talking simply about like, can this be done in a way that we would have a good result? I think for the vast majority of patients, the answer actually is yes.
Okay.
And the reason is there's a lot of things that you can do, even in very thin patients,
Hmm.
to what's called prefabricate the chest wall for a deep flap. This is a bit of a longer conversation, but what I oftentimes do is I'll place a tissue expander at the time of the mastectomy, and I'll kind of control the footprint of the breast, and I'll actually reduce the area that we're required to reconstruct because the footprint for a mastectomy is actually quite a bit bigger than the
Hmm.
footprint for a breast. So a lot of
Hmm.
breast reconstruction is kind of controlling the space. at the
Interesting.
chest wall. And so it's a technique that we use particularly in thinner patients to allow them to have the
Wow.
ability to have a natural reconstruction. So that's a lengthy way of saying that even in the thinner patient, there are
Can be done.
strategies that can be employed to make DIP flap a good outcome.
Okay. What about someone like me? I'm flat by default, kind of just went along with it. And it's been about 6 years. And what if I just said, "Hey, Dr. Torrey, I'm almost 60. Can I do this?"
Yeah. So the conversation there boils down to what I like to use as an analogy for a pillow and a pillowcase. When you're doing a DIP flap reconstruction and someone who's had a prior mastectomy has perhaps had a aesthetic flap closure, you're reconstructing the pillow and the pillowcase. You need the volume and you need
Wow.
the skin and soft tissue. For someone
Wow.
who's having what we call an immediate reconstruction or a delayed immediate reconstruction, oftentimes we already have the pillowcase
I
and
see.
we're
Ready to
filling
go.
the pillowcase with a pillow. So we're replacing the breast pillow with a DIP
Interesting.
flat pillow. We're replacing the tissue expander or implant pillow with a DIP flat pillow. So in your case, where you've had essentially a flat closure, we need to provide for the pillow and the pillowcase. Now, there are ways to do this where we can perhaps put a tissue expander in to re-expand the pillowcase, and then we're back into the swapping out the tissue expander pillow with a deep flat pillow. I think that's what I would typically do in someone who's quite thin and has not had radiation treatment. Radiation treatment's sort of a big part of this. If you've not had radiation treatment,
I
it
did.
does make some of the
Yeah.
issues easier. If you've
Harder.
had radiation treatment, it makes it more difficult.
Yeah.
So, in someone who's very thin and has had radiation treatment, oftentimes I'll do what's called a stacked DIEP flap, where I'll use the skin and fat from the abdomen, where we need to now recreate the pillow and pillowcase for your radiated side. And then on your non-irradiated side, we would perhaps do something like a gap flap, where you're taking tissue from the buttock area and using that for your reconstruction. And this is becomes a lot of surgery. So this is a real conversation
Okay.
for what the options are and what the recovery looks like, what the outcomes would look like. But again, there certainly are options, and it boils back down to picking the right operations to fit your
Person.
lifestyle, your
Yeah.
needs, your kind of aesthetic and reconstructive outcomes. So that's where the nuances of the discussion are really important.
Yeah, because I've also heard this is a pretty intense surgery. I've been told it's what, is it 15 hours? Is that correct? Is that,
For a deep flap,
yeah.
it's typically about for a bilateral deep flap should take about 6 to 7 hours, which is a long time. But I always tell
Yes.
patients, it's not like we're inside the abdomen like a gallbladder or a hysterectomy or a colon operation or an appendix. It's not
Yeah.
inside the chest like a heart operation. We're still dealing with skin and fat.
Wow.
The reason why it takes, 6 hours or so to do is because it is a very technical operation. We're not
Yes.
using any of the muscle. We're not injuring the muscle. We're focusing on the skin and fat. But I think that is a real operation, 6 to 7 hours. It's nothing
Yes, it
to be
is. Yes.
trivialized.
Yes.
And I think the recovery here really is 3 to 4 weeks before you're getting back to some level of exercise patterns, some level of consistent physical activity. The drains, which are very uncomfortable, are in place for 1 to 2 weeks. So these are all things that have to be discussed, and patients have to have a expectation of what is
Yes.
going to happen to them. And again, it boils down to why those first conversations are so important. Um, Ultimately, I think in the long term, patients with DIP flap do better in terms of their overall recovery, their satisfaction with aesthetic outcomes. This has been validated in survey questionnaires that are validated tools for aesthetic breast outcomes. And in my own experience, certainly my deep flap patients, I think, have a more favorable outcome, a more long-standing outcome than my implant patients. I think
Interesting.
implants are less investment early on, less
Okay.
emotional investment, certainly less physical investment, less time for surgery, with the potential for more issues down the road. Whereas a DIEP flap is certainly more investment upfront from a time, energy, recovery standpoint, but fewer issues down the road.
Okay. Okay. I want to ask you about the nerves. It's a hot topic
Mhm.
for me. I had a
Sure.
botched foot surgery. I'm still dealing with major nerve issues 2 years later. Nerves and fascia, topic that's not talked about enough. I didn't know that it was the fascia that was totally, it was scar tissue and fascia all messed up. So, what about people going through this? Can you talk about, scar tissue and nerve damage, anything that could happen? It's just really hot on my mind right now. So, because even after my double mastectomy, and I post about this often, that I felt bugs all across my chest, and nobody educated me and said, your nerves are rewiring, you cut them. So there's a lot of cutting going on here. So if you don't mind helping patients understand what's going to happen here.
Yeah, I think sensation is a big area that we have to discuss with patients. And so there's sensation at the abdomen and there's sensation at the breast, and they're both impacted. So
Yes.
at the breast, you've had a mastectomy. And even if you've had a nipple preserving mastectomy, oftentimes you've had the nerve supply removed to the nipple complex. And that's where the resensation component, Dr. Pellet has talked a lot about this in terms of resensation of the nipple areola complex. I think that there's some good evidence that we can improve sensation to the nipple areola complex, certainly to the overlying skin and soft tissue with some of the resensation techniques
Wow.
that we're now seeing.
That's
The
incredible.
second area here is the abdominal sensation. And as you pointed out, there are nerves that come up through the fascia into the skin and fat that we're transplanting. Now, most patients have numbness at the abdomen, and all types of numbness improves with nerve regrowth. And nerves grow about the same rate as our hair grows, which is about an inch per month. So if you're talking about 6 to 8 inches at the abdomen, 6 to 8 inches at the chest, we're talking about a 6 to 8 month time frame before you start having some of that regain of sensation. And sensation always comes back in the same predictable pattern. It's deep pressure sensation, followed by pain and temperature, followed by light pressure sensation. By the time we get recovery of lighter pressure sensation, now we're about a year out from surgery. And
Okay.
those kind of shooting, tingling, burning type pains that you were
Yes.
describing are very
Yes.
characteristic of
Yes.
nerve regrowth. And many times these are worst at around 3 months from
Okay.
surgery. That's when
Interesting.
everything is kind of
Crazy.
raised up, the scars are
Yeah.
red, things are itchy, because there's a
Yeah.
tremendous amount of healing going on in this
Yes.
time frame.
Yes.
I love things like infrared sauna, uh, techniques like that that are very helpful for like vasodilation, for bringing a blood flow to your scar. So it's something I employ quite a bit with our patients. But the take-home message here is that first 3 months, there's a ton of biological activity, and those are the time frames where people have these, again, itching, burning, shooting type pains associated with nerve regrowth.
So appreciate you talking about this. Nobody tells us this. And it's really important, especially with this type of extensive surgery,
Sure.
or any of the surgeries, because again, I kept calling and saying, what's going on here? So let's talk about the procedure itself. So you're taking the fat from the stomach, you're putting in the breast. Let's talk about what happens, over time. So it sort of just, does it just conform to this beautiful breast? Like how does it shape itself? And I know Beth talks about how it moves naturally, it feels natural. And there's just a great feeling from a lot of survivors that I talk to that it's their own body. That's very comforting as opposed to implants with something foreign and all of that. So can you explain like how somebody, once they get this done, if we just like we talked about the nerves, how is it going to feel over time?
Yeah, I think a difference between implants and deep flap is deep flap is tissue. So it feels like tissue. So if you grab your tummy when you're sitting down, you can feel what that tissue feels like.
Yeah.
That is the tissue that is being transplanted. It will feel the same.
Okay.
So when it's cold, an implant can get cold. That's known as cold intolerance. Deep flap stays warm because, again, it's tissue that has a blood supply to it. It has an artery bringing blood flow to the tissue, a vein taking blood flow away from the tissue. Over time, blood vessels grow into the tissue, just like a paper cut heals. The
Interesting.
deep flap heals with the ingrowth of tissue. And over time, scars soften. It takes 6 months to a year for any scar, whether you have a young child who falls and uh, has a cut below their chin versus a deep flap. It's the same process, which is scar softening. And as the scar softens, the tissue softens, it becomes more like normal tissue, but it doesn't quite get as droopy as normal breast tissue. It sort of stays relatively perky. Why is that? Because there is a bed of scar there to maintain the tissue positioning. Now, oftentimes at the 3 month mark, we'll do a phase two surgery, which
Okay.
is designed to improve some of the aesthetic outcomes. So
Oh,
it may involve repositioning the skin and fat. It may involve adding some fat from fat grafting. It may mean a revision to the dog ears at the abdomen, sort of the areas at the margins of the abdominal incision. It may mean even
okay.
lowering the abdominal incision so it sits more at the bikini line. A lot of things you can do to make the aesthetic outcome better. Fortunately, all these things are covered by the Women's Health Care Act of 1998, which is a federal mandate to insurance
Yes.
companies to cover breast cancer reconstruction. So a lot of these techniques are designed to improve the aesthetic outcome,
Okay.
but a lot of what we do at that first surgery, that first reconstructive surgery, dictates the future course. And ultimately, the goal with that first surgery is a natural, soft, um, uh, very
Warm.
normal feel to the
Okay.
tissue. That's the goal with that operation.
Okay. What about deep flap and radiation? Can you talk about that? You know,
Sure. Yeah. So I always tell patients that if somebody needs radiation treatment or has had radiation treatment,
hmm.
I do not recommend an implant-based reconstruction. So
Interesting. Okay.
a
Because,
lot of radiation, a lot of this is a game of rock, paper, scissors. Rock beats
yeah.
scissors. Radiation beats almost everything except
Yeah.
for deep flap. Deep flap beats radiation as long as
Really?
it's done in the right way. So for
Okay.
someone who I know is going to need radiation treatment, we'll place a tissue expander, and that's known as a delayed immediate protocol. And we'll place the tissue expander to maintain the overlying skin and soft tissue, maintain the pillowcase, let them go through radiation treatment, and then remove the tissue expander pillow and replace it with a deep flap pillow about 3 months after they've completed radiation treatment. And in this way, we're preserving the natural reconstruction, but we're avoiding the radiation damage to the deep flap tissue. Radiation causes what's known as a fibrosis, a scarring,
Oh, I have it.
that can
Yeah.
lead to, yeah, increased range of motion issues,
Can't
increased
move
risk
this
for
arm.
cellulitis. Yeah,
Can't
increased
move
risk
it.
for cellulitis. All that kind of tightness is because of what is in effect a burn. Radiation is a burn, and it
Mhm.
leads to a contracture. And what the deep flap is doing is we're interposing normal, healthy,
Interesting.
supple, soft skin into that area of burn, and we're releasing that area of contracture.
Wow.
So it can improve lymphedema type problems. It can improve
Wow.
um, range of motion type problems. So from a
Incredible.
functional standpoint, I think deep flap, particularly in the setting of radiation treatment, has obviously not only cosmetic advantages, but in the setting of radiation, really very dramatic functional advantages.
This is so excellent. I bet so many people, hopefully, who are watching this had no idea because I had no idea. And again, I was way too late to be educated afterwards. It was like almost 8 months later that I even knew about deep flap. I want to be respectful of your time, and I wanted to
No,
see
no
if there's
worries. We're in good shape.
we're in good shape. Okay, so let's talk about failed or painful, whether it be deep flap or implant reconstruction. That's a big deal.
Sure.
A lot, look, I
Yeah.
have a botched foot surgery. I've been dealing with it for 2 years. So I think we need to talk about not only that, but also making sure people are truly educated to find the right microsurgeon to do, if I'm saying it correctly, the deep flap procedure, because this is a very unique skill from my understanding. And so if we can talk about all of this, that would be very helpful.
Yeah. So, you know, we never like to talk about failures, but failures are devastating problems. And whether it's an implant infection or pain associated with an implant, or certainly a failed deep flap, like these are very, very difficult problems.
Yes,
So the
they're
best
real.
way to, yeah, the best way to avoid a problem is to avoid that problem, to have a
Yeah.
plan, so you don't
Yes.
get yourself into that problem.
Yes.
And it's why understanding these variables that we've been talking about, body mass index, radiation treatment, perhaps prior abdominal surgery, all these things are really important. Figuring out the right sequence of events, use of the delayed immediate protocol, the timing of radiation treatment. All these things are important things to make a part of the plan. When it comes to implant failure, I think the issue is more the risk of an infection associated with a prosthetic tissue expander
Okay.
or implant at the time of the mastectomy. So if there's an infection in the 2 to 4 week time frame after
Uh-huh.
mastectomy, that's when we run into real problems with a prosthetic-based reconstruction. Um, Beyond that 4 weeks, I worry less about an infection, assuming the patient's not been radiated. And then it's more, is the patient having pain, discomfort, perhaps other breast implant illness associated type symptoms? So
Okay.
that's kind of the implant piece of this.
Yes.
Primary concern is infection. Primary concern is healing after the mastectomy. With a
Yes.
deep flap, the concerns are different.
Okay.
I don't worry about an infection really because it's tissue. Tissue is not as apt to get infected. Now, there
Mhm.
may be some wound healing problems, particularly at the abdominal scar. Those are
Okay.
things that we may have to deal with. Again,
Mhm.
this has to do in large part with how the flap is designed,
Yeah.
optimizing the patient's nutrition, staging things
Interesting.
adequately after chemotherapy,
Mhm.
typically 4 to 6 weeks after completion of chemotherapy. But the primary issue with the deep flap is the blood vessel hookup, is hooking up one artery and one vein to provide a blood flow to the tissue. And um, this is where choosing the right surgical team is really important.
Yeah.
You need people that do this in high volume. I
Okay.
would say a minimum is 50 deep flaps per year. That really is the minimum. I think it's best to choose a team
Team.
where there's more than one microsurgeon available,
Interesting.
particularly in the setting of a bilateral reconstruction.
Okay.
Um, you want folks that have been doing this for, you know, a reasonable amount of time. I think,
Mhm.
really 5 years is
Okay.
probably the bare minimum for someone who's doing deep flap reconstruction. I think that it's very important to talk to them about what happens in the setting of a failure, and they should have a plan B and a plan C in mind. And I think those are the types of things that are very important when you're evaluating your surgical team. You want somebody not only with experience, but also focused on microsurgical breast reconstruction, because it's not the type of thing that I think you can do and do other things well. For example, you can do um, a mommy makeover and do maybe rhinoplasty surgery, or you can
Mhm.
do a mommy makeover and have a big liposuction practice. But it's very hard to do deep flap surgery and do other stuff. You
Okay.
kind of need to
Okay.
focus in on deep flap surgery. And so it's why I don't think that there are, going back to your very first question, you know, even in this day and age, there's not hundreds of very high quality deep lab centers. I think there's probably about 10 to 20 that I would
10 to
say are
20.
very high
Okay.
quality.
Hmm.
And I think the challenge for patients is really identifying one that is very high quality, that's in their
Hmm.
geographic area, that they can, feel good about.
Is this globally being done, deep flap, or is this in a US thing? Do you know?
It's really a Western, Europe, America
Okay.
type of operation. It's being
Okay.
done a bit more in India and China, but it's not the same level
Okay.
of um, surgery. I
Okay.
think that, to be honest, there's probably a lot of very bad reconstruction that's being done.
Yes.
I know I've seen many Indian patients. I'm Indian myself. I've seen many Indian patients who've been treated in India that have had problems with reconstruction.
Yeah.
And I think, there certainly is not a good alternative there from a resource utilization standpoint.
Yes.
But I do think that as people become more connected, there will be a patient-led drive for
Yes.
these types of procedures. And there
Yes.
certainly are outstanding surgeons, across the world that have the capacity to do these things.
Yes.
Part of it is a resource utilization standpoint, but I think the history of breast cancer care has really been patient-driven. We think about
Wow.
the radical mastectomy back in um, the 40s and 50s when it
Mm.
was being done at Johns Hopkins, and then we um, evolved to the modified radical mastectomy, which then became the skin sparing mastectomy, which then became the
Mm.
nipple sparing
Yeah.
mastectomy,
It's
which then
evolved.
became the nerve preserving nipple sparing
Yes.
mastectomy. So I think each generation has seen a
Yes.
further improvement in the understanding of the biology of breast cancer
Yeah.
and realizing that we can do less and not
Yes. Yes.
compromise outcomes. And I
Yes.
do think that a lot of the credit there goes to patients and patient advocacy groups that really push,
Yeah.
the medical professionals
Yes.
to improve their understanding and
Yes.
improve what they can offer patients.
Yeah, I mean, and that's a great way to kind of just wrap this up. I mean, this type of conversation is, I mean, I would have loved to have had this 6 years ago. I mean, this and deep flap was around, so it is really sad. My senior medical advisor, Dr. Barry Rosen, said if you don't go to the right place and not being offered some of the latest advances, we're so overwhelmed, when we're diagnosed. I think the hardest part about reconstruction that doesn't get enough conversation, in my opinion, even out on social media, everyone's kind of going through the treatment, but they don't realize, even oncoplastic surgery, that's a whole section here on Learn Look
Yeah.
Locate with Dr. Rose, and that's something that can be done, So um, as we wrap up, Dr. Tiwari, a couple things I wanted to ask you. If you were speaking to a newly diagnosed patient right now, what would be your thoughts? And then also, um, just really having patients from your perspective, empower them with this knowledge. And as we work together to make sure that they have an army, like an armed list of questions. I love what you said earlier, because I want to make this part of our work together so they can come in and they can drive the conversations with questions to ask this particular surgeon, because I did not interview any of my surgeons. I was hysterical. I was like, take the tumor out, let's go, So we just are so panicky. But if we take a deep breath and be more empowered, then we become better patients. And I hope that you're seeing this more, that patients are coming in more educated, but it's a lot. It's like a mini college education, right? So I just threw a lot at you, but just your final words of quote wisdom, if you will.
Yeah, I think the first job of a surgeon is to just listen.
Okay.
Listen to the patient, listen to uh, they are, what their concerns are. And the concerns for every breast cancer patient is, I just want to live through this. I just want to get through this and get through it in a way that I can return to my
Um,
life before
yes.
a breast cancer diagnosis.
Yes.
And I think that's the priority for everybody. I think there is a lot of anxiety, understandably,
Tons.
that comes along with this. And I think my role in many ways is to like control the anxiety in the room
Mm,
and do that with my own energy, with, the experience that they're having, and and then really kind of break it down as simply as you can and
mhm.
reassure the patient you are going to have a good outcome. Like, don't worry about that. That's my job. But this is how we're going to get there. And I
Okay.
think patients need to be armed with information. As soon
Hmm.
as they have information, that brings down the anxiety level. They just want to
That's
know.
true.
They
That's
don't
so
want
true.
a lot of unknowns. You
Yes.
know, I think people are accepting of, okay, this is going to take 3, 6, 9 months to get to the end.
Hmm.
People are accepting of the diagnosis once they've
Hmm.
processed it. They're
Yes.
accepting of treatment, but they need to know what is
Hmm.
happening, what
Yes.
is coming next. And
Yes.
part of this is engaging their significant others, their family members.
Yes.
You know, it's very important to have a second pair of ears and eyes because
Hmm.
your brain will only retain so much out of
Yes.
these conversations. But I think a very simple set of questions that one can ask is, what is the best reconstruction for me? And why is that the best reconstruction for me? And are there other alternatives? And please explain to me why those are not good alternatives for me.
Hmm.
I think if you just start there, that
Hmm.
will uh, evoke a lot of meaningful responses from your surgeon.
That's great. That's great. I love that you brought up anxiety. And that is one of the reasons why I do what I do the way that I do it. This is hard enough, So let's calm the mind down because then we can process the information and really embrace what's happening. More young women are getting diagnosed, and this is a lot for them. So we really need to make sure that young and old, it's on the rise. So if you guys are like have the magic wand to get us back to somewhat of a normal life, once we get kind of walk through the fire a little bit and get to the other side. When I talk to Beth, she's so happy. So it's wonderful to hear, that her results were so great and she's so glad she did it. And that's probably music to your ears as well, right?
Yeah, I love hearing that. I love that she's, getting back to whatever she likes to get back to. I tell people if
Yes.
you want to go, if hiking is your thing, if
Yeah.
uh, bicycling is your thing, if pickleball is your thing, we'll get you back there.
That's awesome.
Um, but it's a journey, and we're
Yeah.
gonna go through that journey together. And by the end of it, just rely on us using our expertise to get you where we can get you.
Okay.
And the goal is as normal and balanced and, symmetric as possible.
That's amazing. We are so grateful, Dr. Tiwari. Anyone watching this, you're so fortunate to have this information today. And I'm just incredibly grateful to have you part of Learn, Look, Locate. So thank you for your time today.
Yeah, well, thank you for the opportunity, and I look forward to working with you.
Yeah, it'll be great.